This is a video for Chapter 24, Drugs for Heart Failure. The picture is showing a normal heart and a congestive heart. The heart on the left shows that the myocardium is thick, but it's within normal limits. And you can see that the ventricles are nice and big to allow enough blood to enter the ventricle and be pumped out. The one on the right shows a congestive heart. So that is what someone with heart failure, that's what their heart looks like. Something has happened with the heart, something's not working well, either a valve problem or a pumping problem, and the heart has compensated by increasing the mass of the myocardium. But this is not an effective way to deal with heart failure. As you can see, the ventricles are very small, so only a small amount of blood is going to be able to enter that ventricle and be pumped out to the rest of the body. Again, we need to review how the blood travels through the heart. So the blood enters the right side of the heart from the venous system, so the inferior and superior vena cava, and then pumps that deoxygenated blood to the lungs. Then the blood becomes oxygenated and it loses carbon dioxide. So that now oxygenated blood enters the left side of the heart, and then it is pumped via the aorta, which is an artery, to the rest of the body to supply and nourish the tissues of the body. The amount received by the right side should equal that sent out by the left side. If not, heart failure may occur. This is a pretty complicated slide that I really don't wish to go through step by step. What I really want you to know is that heart failure equals decreased cardiac output. So what we're going to do, we're going to give medications to increase cardiac output. We can't really fix the myocardium, especially at later stages, that really thick myocardium that occurs in heart failure, but we can definitely do some things to increase the cardiac output. So again, here's the slide that makes it pretty simple to know what exactly is cardiac output and what factors affect it. So cardiac output equals heart rate times stroke volume. So the heart rate, we don't want to increase the heart rate, we want to decrease the heart rate, and then we're going to want to decrease the stroke volume. So we do that by affecting the preload, afterload, and the contractility. This is a great slide to know and to understand. What happens is that someone can have left-sided heart failure, or they can have right-sided heart failure, or they can have bilateral-sided heart failure. The most common type of heart failure is left-sided, so we'll start by talking about that one. So again, we have to remember the left side of the heart, the blood is received from the lungs, it goes through the left aorta to the left ventricle, and then it is pumped out through the aorta, that artery, to the rest of the body. But if something is wrong with the left ventricle or the left side of the heart, then it's not going to be able to pump it out as well. It's going to have a decreased cardiac output. So the blood gets backed up. So where does it get backed up to? It gets backed up into the lungs. So that's why you can remember L for left side of the heart equals lungs, and you get signs and symptoms of congested lungs. So you'll get pulmonary congestion with dyspnea, cough, crackles, and impaired oxygen exchange. When we look at the right side, the right-sided heart failure, again, we have to think about where is the blood coming from. So the blood is coming from the rest of the body. This deoxygenated blood enters the right side of the heart to then go to the lungs to get oxygenated. So if there's a problem with the pumping action of the right side of the heart, things will back up, and they're going to back up into the rest of the body. So then that's when the person gets signs and symptoms such as peripheral edema, hepatomegaly, which is congestion or enlargement of the liver, ascites, which is fluid retention in the abdomen, anorexia, nausea, weakness, and weight gain. So let's take a look at the picture in the middle here. So I see that this person is coughing. They have some shortness of breath, they have some pulmonary edema, so they have some left-sided heart failure going on. But we also see that they have ascites and they have peripheral edema. So this unfortunate person has bilateral heart failure. The pharmacotherapy for heart failure includes slowing the heart rate. Now, we want to actually increase contractility, and we want to reduce the workload of the heart. The first-line treatment is an ACE inhibitor and a beta blocker. So when I see beta blocker there, that makes me wonder though, if we want to increase contractility, why would a beta blocker be ordered? Because beta blockers decrease contractility. Well, we'll keep thinking about it, keep that in the back of our minds, but that's something that we have to consider. An ARB may be added if symptoms persist, so ACE inhibitor is a top choice, but we might also need to add that ARB. Diuretics are used if there's peripheral edema and or pulmonary congestion. So these are the drug classes used to treat heart failure. So we have the ACE inhibitors, the ARB, beta blockers, which is kind of questionable, but they're saying that they should be used as first line along with an ACE inhibitor. Vasodilators, diuretics, cardiac glycosides, which is the drug class we haven't talked about just yet, and phosphodiesterase inhibitors, which we won't talk too much about in this presentation. Can you see which drug class is missing from all of the other cardiac medications that we've talked about so far? So a lot of these overlap with antihypertensives and the cardiac medications we talked about with MI and CVA. So I see that calcium channel blockers are missing, which makes sense to me because calcium channel blockers decrease cardiac contractility, which with heart failure, usually we want to increase the contractility of the heart to increase that cardiac output. This again is a diagram from your book. It just explains the different drug classes and their effects on the vessels, the heart, and the kidneys. So we're going to start with ACE inhibitors. And so ACE inhibitors, their therapeutic actions are to reduce afterload. So they're affecting that aorta coming off of the left ventricle. Again, it's the drug of choice for heart failure. They enhance excretion of sodium and water. So wherever sodium goes, water goes. So that's where they're going to increase diuresis. So this will lower peripheral resistance and reduce blood volume. It increases the cardiac output, and it reduces peripheral edema. We haven't talked about this yet with ACE inhibitors, that they may cause neutropenia, which is a low blood cell or white blood cell count. So we want to monitor the complete blood count, or the CBC. We always want to assess for hypotension. That's one of the main side effects of all cardiac medications. We want to use cautiously with impaired kidney function, hyperkalemia, and autoimmune disease. For client teaching, we want to teach them that it may take a while to achieve maximal therapeutic response. So sometimes it will take weeks or even months to see that maximum effect. We want to teach them about restricting their potassium, because these medications tend to lean towards hyperkalemia. So we want them to restrict that potassium. And again, these medications increase the excretion of sodium in water, so they're more at risk for hyponatremia. So we're going to teach our clients the signs and symptoms of hyponatremia. And we don't want them to use them with any other medication, over-the-counters, medications, herbals, vitamins, but they'll consulting a pharmacist first. The prototype drug for heart failure of an ACE inhibitor is lisinopril. It enhances excretion of sodium in water to lower blood pressure and peripheral resistance. So it's used mainly for the treatment of heart failure and also hypertension. Adverse effects are hypotension, hyperkalemia, that dry, nagging cough that I talked about before, taste disturbance, headache, dizziness, chest pain, nausea, vomiting, and also, as always, angioedema. Angiotensin II receptor blockers, they're very similar actions to ACE inhibitors because they are in the same drug class. And they're used in clients who are not responding to ACE inhibitors or who are experiencing many side effects from those ACE inhibitors. All right, so let's talk about beta blockers. Why are these on the list for heart failure medications? So they slow the heart rate, they reduce the blood pressure, they decrease heart contractility, and they reduce the workload of the heart. But again, one of the adverse effects that we want to look for is heart failure. So we want to be very careful when our clients are on beta blockers to treat heart failure. So we want to monitor for worsening symptoms of heart failure. We want to monitor their liver function and hepatic toxicity. Be aware of any kind of contraindications. Monitor their blood pressure and pulse. We're going to tell them to do that when they're at home taking the medication. We want them to report to their healthcare provider a pulse below 50. Again, report signs and symptoms of worsening heart failure, and for them to stop taking it abruptly. So the prototype drug for the beta blocker class of heart failure medications is carvedilol. It blocks beta 1, beta 2, and alpha 1 receptors. It reduces symptoms of heart failure and slows the progression of the disease. The adverse effects, there is a potential for adverse cardiac effects, things that we don't want to happen, and many drug interactions. So when talking about beta blockers, what they've done, and the studies have shown, that they can be used and they are actually effective with heart failure if they are administered properly. So the thing is that they have to start at a really, really low dose and climb up pretty slow. And it's shown that it helps greatly in heart failure. It helps to remodel the heart, to decrease that thick myocardium. And that if the clients are started on too high of a dose of the beta blocker, then that will definitely worsen their heart failure. So it's a fine balance, but at face value, it would look like beta blockers would not be helpful in heart failure, but actually they are, but only if they're dosed properly. So dosed really low and then increased very slowly. So moving on to vasodilators, they do have a minor role in heart failure treatment. They lower the blood pressure, they relax the blood vessels. There's two main ones, hydralazine, which acts on arterioles, and then isosorbide dinitrate, which acts on the veins. So because of that fact, the two drugs are often combined because they work synergistically to treat heart failure. And it's usually used for clients that cannot tolerate an ACE inhibitor. The prototype drug is isosorbide dinitrate. So again, they act directly on veins to cause the venodilation, dilates the coronary arteries to bring more oxygen to the myocardium. Treatment is heart failure and angina. The adverse effects are headache, reflex tachycardia, and orthostatic hypotension. Diuretics. So these are particularly important if there's a lot of peripheral edema and pulmonary congestion going on. So again, it's going to increase urine flow, it's going to reduce blood volume and therefore the cardiac workload, and it's usually prescribed in combination with other drugs. We want to assess for renal function, monitor electrolyte levels because the client is going to be urinating out a lot of electrolytes along with that fluid loss. Monitor vital signs, intake and output, monitor their blood glucose and BUN. For client teaching, we're going to monitor their sodium intake. So we don't want them to eat a lot of sodium because that's going to keep more water on board. We want them to report significant weight loss, report fatigue and muscle cramps. That could be associated with an electrolyte imbalance. And then changing positions slowly because their blood pressure is going to be lower now. So what we tell clients is that we want them to weigh themselves daily, to weigh themselves at the same time with roughly the same clothes. And what happens is that if they're losing too much fluid or if they have too much fluid on board, then they'll increase their weight pretty significantly from day to day. So a pound or a couple pounds from one day to the next. And when someone increases or decreases their weight that quickly, it's most likely water weight and it's not fat gain or fat loss. The prototype drug for heart failure diuretics is furosemide or Lasix, which is given quite frequently. The mechanism of action is that it prevents reabsorption of sodium and chloride, primary in the loop of Henle. So it's called a loop diuretic, and it increases urine blood flow. And it reduces the blood volume and cardiac workload of the heart. So again, it causes diuresis, causes hypotension, and this is a type of diuretic that is non-potassium sparing. So it's like the thiazide diuretics where they lose potassium. So adverse effects can be hypokalemia. So we're going to want to tell these clients to increase their potassium, their dietary potassium, and possibly a dietary potassium supplement. Because of this shift in potassium, they're at risk for dysrhythmias and also dehydration because they're urinating so much. So this is a new drug class that we haven't talked about just yet, cardiac glycosides. So they actually increase heart contractility, which is one of our goals. They slow the heart rate, they improve the cardiac output. They used to be first line for heart failure, but studies have shown that ACE inhibitors are superior to these cardiac glycosides. So they have become second line in the treatment of heart failure. We want to evaluate for ventricular dysrhythmias. We want to assess their renal function, monitor for any drug interactions, because there can be many, and also assess for toxicity. These medications, particularly digoxin, has a really narrow margin of safety. So it's one of the medications that we can take a blood test to make sure that they're in the therapeutic range and they're not, they don't have a toxic dose on board. So client teaching is that we want them to monitor their therapeutic levels with laboratory tests. So we're going to tell them how often we want them to get their blood checked for the medication in their system, to know the signs and symptoms of toxicity. A big one is that we want them to monitor their pulse rate, report any weight gain, and then to eat foods high in potassium. Because if they're hypokalemic, then that can predispose them to digoxin toxicity. So this is a prototype drug that I'm talking about, digoxin or lanoxin. It inhibits the sodium-potassium ATPase to increase myocardial contraction. So the primary use is the treatment of heart failure, pulmonary congestion, and peripheral edema. We did not see this drug class with antihypertensives and with MIs or CVA. So this is a pretty narrow use is with heart failure. Adverse effects are dysrhythmias, nausea, vomiting, anorexia, and visual disturbances. And there is an antidote to digoxin. It's called digoxin immune fab or digibind. So the medication for this unit, at least, that I'd like you to kind of focus your attention on will be digoxin. But again, you need to be knowledgeable of all of the other drug classes that are used to treat heart failure. And that's it for this one.